Thanks to all the speakers for very good talks, and thank you to everyone for sticking to time. As Professor Omar said, we now have time for discussion and questions. We have about 15 minutes, so we have quite a lot of time. If there's any questions from...
Thank you, Mr. Chair. Thank you, professors. I'm really excited about this talk because it's a development field for liver transplantation. I come from Dar es Salaam, Tanzania. It's a growing field that not only doing the surgeries, but we've been recipient of patients who have received transplant services, you know, from advanced centers like Egypt, here in South Africa, or even in India. And you talked about, Professor Abdelaal, you talk about the transferring of experience. And maybe I could put it as a call for action, that maybe we should not only focus on the, you know, developing the infrastructure for surgery only, as you rightly pointed it out, that this is a program. And it's a gradual thing, because you cannot address it at once. So maybe another area we will be like capacity building, you know, for local physicians and surgeons to manage the post-transplant patients. Because after successful surgeries, you know, we have experienced some quite losses of these patients over time. And we know they go through, you know, these chronic rejections, you know, T-cell mediated rejections. And now there is a rise of acute, you know, hyperacute antibody-mediated rejections, which we didn't have in liver, you know, transplant. And I think it's a gray area for many, many, many physicians, I will tell you, and even surgeons. So if we can develop capacity of post-care transplant, I think, you know, globally, we'll save many cases that they have undergone, you know, expensive surgeries, and they reduce the need for, you know, retransplantation, or in that case, losing the patients at all. I have two cases, I'll tell you. I have lost, they have died on my hand. You know, being a gastroenterologist at home, and with relatively positive of, you know, expertism. But these, you know, they had acute rejections, and there are no infrastructure even to respond for immunosuppressive, for example. You had to depend, you know, to call back a physician or a surgeon in Egypt or India, you know, to call, you know, coordinate care. So again, we lost them on track. The last one I lost was, I think, had an hyperacute antibody-mediated chronic rejection. And, you know, we were just arranging to transfer him back to India, but I think we lost him in the way. So the infrastructure, the basic infrastructure has to be advised, capacitated, even before when we think of establishing, state-of-the-art centers for surgery. Thank you, and maybe I would like your opinion on this.
Thank you so much for your. Thank you so much for your comment. I'm totally with you, and as we explained, the most important step in establishing a liver transplantation program is to understand, the local team has to understand two very important issues. The first, it's a program. It's not an operation and then the patient back home and that's it. It's not like this. Secondly, is a complete collaboration between all the multidisciplinary team. This collaboration is very, very difficult to have. To have a collaboration between your transplant hepatologist and the first you have to choose a reference center with high volume work. Then the collaboration is not a phone collaboration. All your hepatologist has to spend a very sufficient time in outpatient clinic and other center to see the varieties of post-transplant problems, rejection. I'm really slightly astonished to lose a case of acute cellular rejection because if they have slight experience in liver transplantation, very difficult you can lose patients with vascular problem early post-operative. But to have acute rejection in liver transplant is completely different than rejection in kidney transplant. In kidney transplant, sometimes it's very problematic. In liver transplant, liver is immunologically is not that aggressive, and that's why acute rejection, it could be treated very safely with just increasing retacrolimus. It's very, very mild cases with acute cellular rejection. We give pulse steroid if we are sure 100% that we don't have any infection. Viral cytomegalo, for example, very common viral infection post-transplant. Back to our collaboration, as I told you, the local team has to spend a very good time. Interventional radiology is very, very important. If you have a biliary problem post-operative and you don't have an trained interventional radiology, endoscopy, well trained in ERCP, very important. That's why post-operative care for patients transplanted, for liver transplant, especially living donor liver transplant, is very crucial. Collaboration is very important. Spending an adequate period in other centers, all is not the surgery, is not the surgeon. I'm speaking about the interventional radiology, endoscopist, hepatologist. Very, very important transplant liver pathology. Liver pathology is really very important in diagnosing, very early diagnosing, biopsy early when you are suspicious of cellular rejection, for example. All the tools to diagnose viral infection, bacterial infection post-operative are very, very important. That's why it's a complete story. You have to share it with other centers, and then at certain point you will find now we are transplanting with the French team, as I told you, for 4 years. And then I spent a very good time in the center, Hôpital Eduard, performing a lot of cases of living donor, pediatric, and cadaveric transplant. Then we established our center in Egypt. We have our colleagues as a reference. It's slightly complicated, but we have to start it in different centers because we have need to be fulfilled. Thank you.
Ronaldo DeLacy, I'm one of the pediatric gastroenterologists at Red Cross Children's Hospital. So I deal with liver transplants, especially the pre and post. And as you stated, it's intensive and you need lots of resources for these patients. Can't be done as a one-man show. But my question is, in the case of a patient, I've got an 8-year-old patient at the moment, not confirmed HCC, but a lesion that's suggestive of HCC with a normal alpha-fetoprotein of like 1.2, who's had biliary atresia and had a functioning Kasai. And she's actually got normal bilirubins at the moment, no signs of portal hypertension. If the lesion was to be HCC, what would be the way forward? Do you think ablation would be the way forward? Do you think listing her for transplantation in the view that she's actually got normal liver functions? So I would just like to know what the opinion would be with the solitary HCC lesion, normal alpha-fetoprotein, if it turns out to be HCC, with a good functioning Kasai. Thank you.
I think I can maybe, so our experience now through Schuur is we've transplanted not a lot of HCCs, but we've transplanted 7, and we've got someone doing their PhD on HCCs. We haven't had someone that young. I think if it's small and it's resectable or ablatable, and the patient's got good liver function, that we would probably go with that option first, and reserve transplant for the situation where the patient wasn't amenable to one of those other curative intended surgeries. I don't know if anyone feels differently about that.
Yeah, I think also just to check if the patient is within transplant criteria in terms of size and so on.
Just to follow on that question, I was just wondering, we've got a cadaveric program mainly. In Egypt, what transplant criteria do you use to determine if someone's a transplant candidate for an HCC? And has it changed over time?
Yes, when we started our program, any emerging program, usually we choose straightforward cases and very strict criteria as the Milan criteria. And by time, we start to up to 7 criteria. And now, in our center, we are adopting up to San Francisco, up to 7 criteria. But back to your question, this is a very difficult question to be answered by yes or no, or to be answered by I'll do ablation, liver transplantation. It's really highly complicated. The size, multiplicity of the tumor, the degree of cirrhosis, age of the patient is very, very important, as we have, if we have a single lesion, we have incidence of recurrence 25% in 1 year in first year, and then we have an incidence of recurrence 75% after 3 years. It depends on the context. If a baby, for example, a child with a cirrhotic process and he has a lesion proved to be hepatogastroenterologist or hepatoblastoma, it's a completely different issue. But I think the question is very, very difficult to be answered by a simple answer. And it depends on the context and a lot of factors.
So just one comment quickly before we move to Wendy. The other thing that I think is useful in these patients is to discuss them in an MDT meeting. And you know, we haven't had lots of children with HCC, so maybe we should discuss it at the adult MDT meeting. We'd be happy. But we'd still be happy to do that. Yeah.
I think one of the key points is the liver status. If the liver status is having an advanced liver problem, I think we can go for liver transplant. Otherwise, as mentioned by Dr. Mark, we can go for ablation first.
So the thing is, she's got more bilirubin and an ALT of 35. So she's got a very good functioning sign, no signs of autoimmune.
So surgery is another option.
Wendy?
Just from Cape Town. So, I mean, many countries in Sub-Saharan Africa will be going for living-related programs. And we need to remember the donor as well as the recipient. So do you have a registry and do you have a long-term protocol follow-up for the living donors?
Registry, normally registry is for cadaveric transplant. We have a database, yes, for living donor liver transplant. We performed till now 5,200 cases in different centers. As I told you in my presentation, the breakthrough was in 2001. 2 big hospitals in Cairo started to perform in collaboration, one with the French team, Eduard, and the other was Professor Tanaka from Japan. And then they started to perform a huge number of cases with the other team. And now, after 21 years, as I told you, we have 5,200 cases of living donor liver transplant. The donor registry, we have, as I told you, that with registry, we are in the process of performing registry. We are aiming to start cadaveric transplant within the upcoming month. But for the database, yes, we have a database for all the donor transplanted. We have. And
a protocol for the follow-up, immediate follow-up?
Yes, follow-up for donors all over the world for living donor liver transplant is for 1 year. We follow the patient weekly for 1 month, and then every 1 month for 1 year. Just the first 1 month ultrasound and lab investigations, and then every month lab investigation, and he sent lab investigations.
I mean, I think that's important to stress that the donors do need follow-up. Otherwise, we're going to run into problems as well. So often that isn't built into the program when one starts these living-related programs. So I think it's very important to stress that.
Thank you.
Thanks. Yeah.
Thank you very much for the presentation on the collaboration between Côte d'Ivoire and Egypt. My question is, what was the learning curve in this case that you have presented? Because when we read the autopsy, and the conclusion was that the patient was not adherent to highly active antiretroviral therapy. And in my understanding, liver transplantation, it's just like pilots taking a big Boeing 707 into the air and landing properly. But to then hear 5 months down the line, the patient died of non-adherence. Was it a question of the internal medicine or physician not following viral loads? I just thought it's important for us to hear what was the missing link, or is it a patient-related factor? I hope my question is clear.
I will try to speak in English. For this first case, we noticed that after the surgery, the patient have a very bad family environment. She was alone at home. So the follow-up was difficult. For the immunosuppressive therapy, we have to buy it. it was a challenge. We solved it, but the social condition wasn't sufficient to follow up. So we think that for this case, we were not care for the social condition before giving the indication of liver transplant. So I think the bad issue here was about social condition.
Thanks, Professor Keli. Just to follow on, my impression is that one of the benefits of a liver transplant program is the upskilling of everyone who's involved, the surgeons, the anaesthetists, the interventional radiologists, and as you alluded to in your talk, the new equipment that you got. I'm sure your program has benefited from that, and do you feel that you are doing bigger liver cases, or that your liver program is better because of that one transplant that you've done?
What I can see is that we are going to have government support to have all the material, the infrastructure necessary to continue the program. At the beginning, I haven't no support, but now Ministry of Health is with us to push the program forward. And I think the future will be better.
Okay, we're starting to run out of time. We've got time for 2 more questions. There's one question there, and then that'll be the last question.
Hello. I just wanted to comment on, I found the history of the evolution and the partnerships with liver transplantation in Africa really inspiring. I just had 2 quick comments, perhaps they're more light-hearted, so I'll be brief. One was, I've been involved in the investigation at WHO of the acute severe hepatitis in young children. Fortunately, that event now seems to be on the wane, but with over 1,000 cases, around 8 to 10% had liver transplantation. And in all those countries that were able to do these life-changing but life-saving events, there were no deaths. Overall, the death rate was around 3%. But in the 67 or so liver transplants done in over 1,000 cases, there were no deaths. So it was extremely important. But I just wanted to add a little bit of history. I had the privilege in the early 80s of doing my first research ever on cyclosporin. I was assigned 15 rats, but this was in Cambridge. But the really important work was being done on beagle dogs and in pigs. But we were targeted by the anti-vivisectionists, and you forget really that organization, which was labeled a terrorist organization in those days. And they kidnapped all the beagle dogs in the Babraham Research Institute and all the pigs. Roy Khan had his house daubed. We were targeted. His children were targeted. Those were the days. There was a very strong collaboration between Cambridge and Cape Town, and I came to do my medical student elective here and had the pleasure of a lot of dashing young transplant surgeons I was introduced to, and introduced to Christian Bernard. I then went on to do my surgical house job with Roy Khan, and instead of learning about general surgery, it was liver transplants. And that was at the time when 30% of patients died on the table. You know, we forget those times, and I was the one needing to do informed consent, so it still left a real mark. And my final little anecdote was that at the end of my time there, I received a bill for £200,000 for organising all the helicopter transfers. And this was at a time, I think my salary was $15,000 a year. So that took some sorting out. But anyway, it was just prompted by the very interesting history of evolution and those early days, which were pioneering days, and formidable, what was faced at that time. Thanks.
Thank you.
I was about to say that you've kind of just touched on what my comment was, which is that a liver transplant program is very much not just the surgeon. The transplant hepatologists, the pathologists, interventional radiology, all play a massive role, and I mean, all the way down to even the social workers and coordinators that are involved. You need to get these accurate diagnoses fairly quickly with individuals that are experienced in transplantation. And in settings that are not experienced in transplantation, this can be very, very challenging. As your surprise in terms of why would an acute rejection pass away, if the experience isn't there, then it is difficult, I'm quite certain. But that also then highlights another thing, which is the importance of setting up these sort of structures, because it's not just an isolated thing. It is building up and bringing up the entire healthcare sector around that transplant service. The radiology service improves, the pathology, your ancillary services improve, and that is aspirational. Where we need to focus in Africa is we're aiming there and we're working towards it.
Thanks everyone. That's the end of the session. Thank you very much.